Well, there it goes. Hi, welcome to Mad Medicine with Miss P. I was gonna do like a little nursing consideration video, but I feel like I've done some along the way. We can touch on a couple. Like I said before, kind of common sense stuff is if you give an antihypertensive, you're going to check the blood pressure before and afterward, obviously keeping an eye on it, making sure it works, not just an hour after, but continuing on after. So if at ever some point in the afternoon the patient complains of any dizziness, nausea, anything like that, that should be the first thing you want to check is their blood pressure, and also know when to hold it, like we talked about before. Depending on how these medications work, it'll let you know what you should give and what you should hold. So, and without getting deep into that, just remember, read the action of the medications and know what to expect when you give them. So those ACE inhibitors, the beta blockers, those things are not even, mild diuretics. Those are not things that are going to significantly change their blood pressure. But I would watch those calcium channel blockers, vasodilators, the heavier diuretics, like, 80 of Lasix. Those are things you want to watch. The same thing with your antispasmodics that we talked about last week. Anytime that someone's on an antispasmodic, especially one that retains a blood level, is you want to watch that blood level. Tegretol, Dilantin, those medications, even like digoxin with our antidysrhythmics, those need to be at a therapeutic level. And then, of course, you're looking for arrhythmias with digoxin. Now, it doesn't mean it's going to cure their arrhythmia, but they should stay functional and, at a minimum. Just like with your seizure medication, it may not cure their seizures, but you do want to watch for duration, characteristics, and severity of those seizures and record them. And of course, safety is number one. Always make sure that you're protecting them. Don't try to hold them down or stop them from doing anything. God forbid, don't you put your finger in their mouth to try to stop them from biting their tongue. That's just dumb. That's how you get your finger bit. So sometimes there's nothing you can do about it but turn them on their side, especially if they bite themselves and they bleed or anything like that. So those are kind of common sense nursing considerations for most of those things. And they're not going to change significantly. I know the book says stuff like, listen for crackles or monitor edema with like metoprolol, and we talked about that before. That's because those patients most likely have CHF. It doesn't necessarily mean they're going to develop crackles. It means that you're making sure they're not in fluid overload because they already have kidney failure and congestive heart failure. But I was going to talk real quickly just about a few medications that are for hyperkalemia. So, and we'll talk about some, maybe we'll do some electrolytes next week, but the potassium one is kind of a big one, and I just made a note on that to mention it. Because potassium being too high or too low with that narrow window can literally be fatal. And a lot of patients, ironically, have developed quite a tolerance to a higher or low potassium, but for some of us that can happen too quickly. We don't have a tolerance to it, and I know some bulimic patients, it can get really high and they can tolerate a high number. And then, of course, your dialysis patients, they tend to be able to go a little high and a little low just because they've been chronic for so long that, kind of like diabetes with those crazy blood sugars, they're not symptomatic until they're 600, which, seems insane, but it's the truth. Just like hypertensive patients come in crazy and they're asymptomatic because their body's used to it, same difference. But when we're talking about potassium, and not to say that we won't get into some electrolytes, I'll do just like a little mini electrolyte thing like I used to do with my IV therapy course. But when we talk about electrolytes, especially potassium, it's really important to recognize what we can use to get that potassium down. Now, if it is too high, obviously we're going to give oral potassium and a potassium drip real slowly, and we know it burns like a mother. Or even at 25 diluted, it still kind of burns, but you have to get it in. So sometimes you just have to do what you can to try to limit the burning, but still get that potassium in as quickly as you can safely. So sometimes you'll give like 20, 30, or 40 megs, milliequivalents orally, and then also hang an IV drip depending on how low it is. But when it's too high, that's a kind of interesting one. So if you understand how potassium works, especially with other electrolytes and how they become buddies, it's really important to know that you can basically help hyperkalemia with 4 different things. First of all, one of the most easy ways to get rid of potassium, obviously, is with a diuretic. So you'll see like 80 of Lasix, and it'll be IV every 6 hours, or 20 of Lasix or 40 of Lasix, depending on how severe it is. Also, depending on their hydration status. So if they can tolerate the Lasix, that's what we'll give initially to try to drop that potassium, because as we know, Lasix works by inhibiting the sodium and chloride reuptake, the kind of hold on to at the loop of Henle. So instead of reabsorbing those, it inhibits that and they are sent to the bladder. Well, potassium's best friends with sodium. So it's where sodium goes, potassium will follow. So that's kind of how you can get rid of that. So that means you can pee it out, right? So you can also poop it out. If you haven't already seen K-Exalate, and basically I always joke that I will shake up the little kind of the little tub of K-Exalate and say, well, why don't you go ahead and sit on that bedside commode while I shake this up for you and, scan it and give it, because that's almost how fast it works. So sometimes we'll give 30 or 60 grams of the K-Exalate and it will work pretty quickly. So that binds K-Exalate, potassium K, right? Potassium exalate, kind of a laxative. It binds with that potassium and shoots it out their butt, and I mean quick. So we'll give the K-Exalate to try to get them to poop it out, right? So you can pee it out and you can poop it out. Now, depending on how high it is, and I have done all 4 on a hyperkalemic patient before, years and years ago, the hospital I used to work. So you can pee it out, you can poop it out, or you can give an amp of D50 IV with 10 units of insulin IV as well. And that will kind of bind together so that insulin and that glucose will bond together and get into the cell, so it doesn't significantly alter their blood sugar. But what it will do is that glucose will grab potassium and kind of drag it into the cell with it. So you can pee it out, you can poop it out, and you can drag it into the cell. Basically what you're saying, the vessels, the vascular, in general, the vasculature is saying you don't have to go home, but you can't stay here. So they're going to pee it out, they're going to poop it out, and they're going to drag it into the cell to get it out of the bloodstream. And right now, because a elevated potassium level, as we all know, lethal injection could in fact be lethal. So if that doesn't work, or they're still concerned with it, or they're symptomatic, we can also hang calcium gluconate, which will kind of balance out that potassium level. So because calcium and potassium are the 2 most important and vital electrolytes for the heart, not to say magnesium isn't important, not to say sodium isn't important, but those 2 kind of do it, are kind of congruent in that electrical and muscular contraction, right? So calcium is to conduction, like potassium is to contraction. So in that calcium, that the electrical current is flowing through there 100 miles an hour, and that contraction is equivalent, we can kind of balance those out a little bit. So when that potassium is too high, we're going to have erratic contraction. We can almost like say, it's an awful metaphor, but it's also like, oh yeah, well, so can I. So when that potassium is really high, you can elevate that calcium as well and kind of balance them out. So you increase the threshold of what the heart can tolerate by balancing out the electrolytes and the electrical and the contractual components of that heart. So when the potassium is really high and you bring up that calcium, it's almost like the heart is still too high and too elevated to where we want it, but being balanced kind of just keeps that thin line that you fall off on one side just a little elevated or a little equal until we can get where we want, and then you can get that potassium lowered with the other medications, and hopefully that calcium will kind of sort of hold it there, and then we'll get rid of the calcium also and maybe be back to a reasonable level. So if ever you've seen that hanging and you understand how potassium works, it's a really good idea to kind of explain how we can get rid of it. And if you just remember, you can pee it out, you can poop it out, you can drag it into the cell, or you can balance it. Those are the 4 ways we deal with hyperkalemia, and you will see it. And I have seen all 4, and I've done all 4 before. Sometimes it's just a little potassium that takes care of it, but that calcium level is real narrow, and you don't have a whole lot of time on that. So that's really all I was going to do today. I've got a bunch of running around and stuff to do, and I got to get going on that. But I just wanted to at least put that out there so I can mark it off my list, and then maybe next week I'll do some of the other electrolytes. I have what did I do with my electrolyte book? Did I take that back? Oh, you know what? I think I gave it to the gal who's going to do my IV therapy group. Oh man, that was a good book to hold on to. So I don't know. We'll do electrolytes or or something else next week. I don't even know. I got a lot going on. I don't even know that I pulled out a pet peeve. Um, I have a pet peeve just for my son and other teenagers. Could you not call me bra? I just that's I don't like that. I don't respond to it. Bro, man, or bra. I don't please don't just don't. It's basically my son. My daughter's getting to that a little bit, but like even when he's around his friends, they say that also. No, bra, man, dude. No, you can call me Miss P. Even might let you call me by my first name with a miss in front of it, but um, please refrain from calling me bra. That's not ever gonna fly for me. And that's it. Same as always. Forget your fears. Forget your failures. Face your fears. Follow your faith. I always think that's a good thing to live by, and maybe one day I'll be able to do that also. But that's it. A quick little 11-minute video this time, and the next week I legit don't know what I'm gonna do. I know it's awful. I have nothing prepared. All of the YouTubers I watch, they have this like long, involved script that they do. Of course, I just watch true crime basically, but I don't do anything. I literally just come up here and sit down and say what is on my mind. You know what? I may even start my little list of ridiculous things people have said over the years. I might throw that in there and break it up a little bit. And if I come up with something else or somebody mentions anything they want me to do a video on, I can. Other than that, this is getting more work than it's worth. Not that I prepare, but it's a little stressful. So we'll see. Anyway, okay, so that's it for today. Have a lovely one, and I'll catch you next week. This is this is not going to work. Maybe it's just the third time's the charmer. You know what I should do is I should just like keep hitting it every so often, and then